1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charge
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
You know, it's really fascinating how differently you can read the same medical texts depending on your mindset.
Oh, for sure. Absolutely.
Because you look at the cardiovascular sources you shared with us for this deep dive, and on the surface, it reads like an instruction manual.
Yeah.
You've got the structural diagrams, the hemodynamics, the pressure monitors. It feels very clean.
Yeah.
Very, static.
Which is incredibly deceptive, right? Because
Yeah.
the moment you apply that information to an actual living, deteriorating human being in the ICU, all of that static physiology just becomes a rapidly moving target.
And that is exactly our mission today. We are taking the textbook sources you provided on cardiovascular function and monitoring, and, well, we're going entirely off the page.
I love it.
We are looking at this strictly through the lens of an elite ICU intensivist and a critical care nursing instructor. We're aggressively applying the 80-20 rule here.
Yeah, we aren't doing a basic anatomy review today.
No. We are hunting for the high-yield pathophysiology, like the vital signs, the waveforms, the rapid interventions that actually dictate whether a patient survives the shift.
Because surviving the shift means connecting the dots. I mean, at the bedside, you are basically a translator.
Right.
You have to look at a cellular biomarker, cross-reference it with a hemodynamic waveform on the monitor, and immediately anticipate what that means for organ perfusion.
You're constantly hunting for failing physiology before the patient fully decompensates.
Exactly.
So let's just start with the heart's actual engine, cardiac output. Because if we're going to recognize a failing pump, we first have to understand the math that keeps the organs alive.
Right, the foundational math.
Yeah, which is that cardiac output equals heart rate multiplied by stroke volume.
Right, and stroke volume itself is dictated by 3 distinct variables. You've got preload, afterload, and contractility.
Okay, let's break those down.
So preload is basically the stretch on those ventricular muscle fibers right at the end of diastole before the squeeze. Afterload is the resistance the ventricle has to overcome to eject that blood into the systemic circulation.
Yeah.
And then contractility is just the intrinsic force of the myocardial contraction itself.
I always try to visualize this mechanically. Like, the heart is a pump.
Sure.
So preload is the fluid loading the pump. It's the venous return filling the chamber.
Yes, exactly.
And afterload is like a kink in the hose it has to push against, the systemic vascular resistance.
That's a great way to look at it.
And contractility is just the horsepower of the motor driving the whole thing.
That mechanical analogy works perfectly because it plays directly into the Frank-Starling law, which is the core pathophysiology here.
The stretch mechanism.
Right. Frank-Starling dictates that the more you stretch those myocardial fibers with incoming volume, the preload, the more forceful the subsequent contraction will be.
It's like pulling back a rubber band. The further you pull it, the harder it snaps.
Up to a critical threshold, yes.
Right.
And that's where the pathology comes in. If you overstretch those actin and myosin filaments in the heart muscle, they lose their optimal overlap.
Oh, wow.
Yeah, the rubber band loses its elasticity, the pump fails, and stroke volume just plummets.
Okay, but let's look at the other half of that cardiac output equation, heart rate.
Okay.
If cardiac output is heart rate times stroke volume, the math suggests that a faster heart rate is always, a net positive for output.
You would think so.
Right. If the pump cycles faster, you circulate more volume. But I know from clinical experience, that's not true. So why doesn't a heart rate of 160 or 180 equal massive cardiac output?
It's actually one of the most dangerous clinical traps you can fall into.
Yeah.
And it all comes down to the mechanics of coronary perfusion.
Okay, explain that.
We have to remember that the coronary arteries, the vessels feeding oxygen to the heart muscle itself, they do not fill during systole.
Wait, really?
Yeah, when the heart contracts, the tissue pressure is just too high. The coronaries primarily perfuse during diastole when the muscle actually relaxes.
So when the heart rate spikes, the entire cardiac cycle shortens. But it's the diastole that gets disproportionately cut down.
Exactly. At a normal heart rate, diastole is about twice as long as systole. But at 180 beats per minute, diastole practically vanilless.
Oh.
So think about the metabolic disaster happening there. The heart is working furiously, requiring massive amounts of oxygen to sustain that rapid rate.
But because it has zero time in diastole, it is actively suffocating its own blood supply.
Yes. It's working harder, but starving itself of fuel, which inevitably causes stroke volume to crash, taking cardiac output right down with it.
That mechanism beautifully explains why we obsess over mean arterial pressure, or MAP.
Oh, absolutely.
The formula is systolic pressure plus 2 times the diastolic pressure divided by 3. And again, diastole gets multiplied by 2 because under normal conditions, the heart spends twice as long in that filling phase.
Right. And that MAP value gives us the average pressure driving blood into the capillary beds. The magic threshold is 60 millimeters of mercury. If MAP falls below 60, the pressure simply isn't high enough to overcome the resistance in vital organs like the brain and kidneys. They become ischemic.
So if we synthesize this into how an intensivist actually thinks at the bedside, your priority nursing action isn't just looking at a single MAP reading.
Right. Not at all.
A single reading of 65 doesn't tell you much. The priority is trending the heart rate and MAP together over time.
Because the trend reveals the compensation.
Right.
Like if you see a narrowing pulse pressure, the gap between the systolic and diastolic numbers shrinking, that is a glaring early warning sign that stroke volume is falling. The body is clamping down, increasing systemic vascular resistance just to maintain the MAP.
Which gives us our classic clinical picture. So, to summarize these 5 things, if you are standing at the bedside and you see a patient with a dropping MAP, a narrowing pulse pressure, and a rising heart rate, they are losing stroke volume and compensating dangerously.
Exactly. And your immediate thought process has to be sustained tachycardia equals decreased diastolic filling and coronary starvation. You need to manipulate those 3 pillars.
Right. So you might need positive inotropes like milrinone to boost contractility or vasodilators to drop the afterload and, unkink that hose.
Yeah, exactly.
But calculating all of this with intermittent blood pressure cuffs is a luxury you don't really have when a patient is rapidly crashing.
No, it's too slow.
You can't wait 60 seconds for a cuff to inflate when perfusion is dropping second by second. Which brings us to the invasive lines. The arterial lines and the pulmonary artery catheters, the Swan-Ganz.
Yeah, these are the tools that give us real-time, continuous waveform data. A PA catheter threaded into the pulmonary artery gives us pulmonary artery wedge pressure, or PAWP, which we use as a proxy for left ventricular preload.
Okay.
And it also gives us central venous pressure, CVP, representing right ventricular preload.
But I want to push back on this a bit because I think it's a massive conceptual hurdle. The sources state we use PAWP to measure preload. Preload is the volume of blood stretching the ventricle.
Right.
But a catheter is a pressure transducer. It only reads pressure. Is it actually measuring the volume of blood?
It absolutely is not. And assuming that it does is a fatal flaw in clinical reasoning.
Okay, thank you.
Yeah, it measures pressure at end diastole. The assumption we make in the ICU is that pressure and volume correlate predictably. We just assume that if the pressure is low, the tank is empty, and if the pressure is high, the tank is full.
But that completely falls apart if the patient has a stiff, non-compliant ventricle.
Precisely. If a patient has severe ventricular hypertrophy from, say, chronic hypertension, their heart muscle is like a thick, rigid leather pouch.
Oh, that's a good visual.
You could have a very low volume of blood in that ventricle, but because the walls are so stiff, the pressure reading on your monitor will be sky high. So if you look at that high PAWP and think, oh, the tank is full, I should give a diuretic, you will completely crash the patient's cardiac output. You always have to account for ventricular compliance.
And even if the compliance is normal, none of these numbers mean anything if the transducer isn't leveled correctly, right?
Oh yeah, the phlebostatic axis.
Right. The intersection of the anterior-posterior midpoint of the chest and the 4th intercostal space. Why is that specific anatomical location so critical?
Because it aligns the fluid-air interface of the transducer directly with the level of the patient's atria. It's purely about hydrostatic pressure and gravity.
Okay.
If your zero reference stopcock slips and falls lower than the phlebostatic axis, the weight of the fluid in the tubing pushes down on the sensor. Your monitor will display a falsely high blood pressure.
And if it's placed too high, gravity pulls fluid away and it reads falsely low.
Exactly. You could be hanging dangerous vasopressors based on a completely artificial reading just because the patient's bed was lowered and the transducer wasn't adjusted.
That is terrifying.
Which is also why we perform the dynamic response test, the square wave test, every shift.
Right.
When you pull that flush valve, you hit the system with 300 millimeters of mercury. You should see a sharp upstroke on the monitor, a flat top, and a rapid drop with exactly 1 or 2 oscillations before it returns to the arterial waveform.
And if it's overdamped or underdamped,
your systolic and diastolic numbers are garbage.
let's talk about the physical risks of these lines, specifically arterial lines. The text mentions keeping the flush system pressurized to 300 millimeters of mercury, delivering a continuous 1 to 3 milliliters per hour. Why 300? Why not just a normal gravity drip?
Think about the physics there. You have a catheter sitting inside a high-pressure artery. If the patient's systolic blood pressure is 140 and your flush bag is only pressurized to 100, the patient's arterial pressure will overpower the bag.
Oh, so it backs up.
Yeah, blood will back up into the IV tubing, it will stagnate, and it will clot. When you finally flush it, you just shot an arterial embolus directly into the patient's hand.
Which causes immediate neurovascular occlusion.
Exactly. That is the nightmare complication. It's why, before you even consider placing a radial arterial line, you do the Allen test to ensure collateral circulation from the ulnar artery.
Right.
Because if that radial artery thromboses and the ulnar artery can't compensate, the tissue distal to that line literally dies.
So, summarizing the 5 core things here. Your priority nursing action, if you see an arterial waveform suddenly dampen, is to first activate the fast flush and check the square wave test.
Yes.
But your immediate next step, without hesitation, is to assess that limb.
Always.
If you see a pale, cool, pulseless extremity distal to an A-line, your brain should immediately jump to neurovascular occlusion. That is a limb-threatening emergency, and you escalate to the provider instantly.
Right. You don't chart it and wait. You intervene.
Absolutely. But let's step away from the monitors for a second. Let's say you don't have a Swan-Ganz catheter. You just have your eyes, your hands, and your stethoscope. We need to be able to recognize a failing pump through physical assessment.
This requires visualizing the hemodynamics as a traffic jam.
Okay, I like that.
If a ventricle fails, it can't push blood forward. Therefore, the blood backs up into whatever system feeds that ventricle.
So if the right ventricle fails, it can't pump forward into the pulmonary artery. The traffic jam backs up into the systemic venous system.
Yes, and that venous engorgement is highly visible. You'll assess jugular venous distension when the patient is at a thumb to 45-degree angle.
JVD.
You'll see dependent pitting edema in the lower extremities or the sacrum. You'll palpate an enlarged, engorged liver.
Conversely, if the left ventricle fails, it can't empty into the aorta.
Yep.
So the traffic jam backs up into the pulmonary veins and into the lungs.
Exactly.
This is where we get shortness of breath, orthopnea, and those notoriously difficult extra heart sounds, the S3 and S4. Let's skip the basics of S1 and S2. What is actually happening mechanically to generate an S3 gallop?
So in S3, the ventricular gallop happens very early in diastole. Normally, blood flows silently from the atrium into the ventricle. But in severe left-sided heart failure, that ventricle is already overfilled from the previous beat. It's distended and non-compliant.
Okay.
When the new blood rushes in, it literally sloshes against the tense ventricular wall, creating a low-pitched reverberation. That slosh is the S3.
Which just screams volume overload.
Yes.
And an S4.
And S4 happens late in diastole, right before systole. This is the atrial gallop. The ventricle isn't necessarily overfilled, but it is heavily hypertrophied and stiff.
Like from chronic hypertension.
Exactly. From years of pushing against high afterload. So the atrium has to contract violently to force blood into that rigid chamber. That forceful atrial kick against a brick wall generates the S4 sound.
And since they are so low-pitched, your priority action is to use the bell of the stethoscope, not the diaphragm, right?
Yep, the bell.
And roll the patient into a left lateral decubitus position to bring the apex of the heart closer to the chest wall.
And while you are auscultating, you must constantly monitor for a pulse deficit. This is a classic sign of deterioration.
A pulse deficit being when the apical heart rate you hear with your stethoscope is significantly faster than the peripheral pulse you feel at the radial artery. Why exactly does that happen?
It's an electrical-mechanical mismatch, most often caused by a dysrhythmia like atrial fibrillation. The heart's electrical system is firing chaotically and rapidly. The ventricles are trying to keep up, so you hear a fast apical rate.
But the output isn't matching it.
Right. Because the beats are so rapid and irregular, the ventricle doesn't have time to fill properly between beats.
So the stroke volume on those premature beats is tiny.
Exactly. The heart muscle contracts, but there isn't enough volume to generate a pressure wave strong enough to reach the radial artery.
Wow.
So you hear a beat, but you don't feel a pulse. That is a glaring indicator that despite a fast heart rate, systemic perfusion is seriously compromised.
So to synthesize the clinical picture here, you walk into a room, your older adult patient suddenly requires 3 pillows to sleep to avoid suffocating orthopnea, and you auscultate a new S3 gallop. Your immediate thought is left-sided decompensation and volume overload.
Spot on.
And if you notice a difference between the apical and radial rates, you immediately suspect an arrhythmia dropping their stroke volume, and you require 2 nurses to count simultaneously for a full minute to confirm the deficit.
Yes. And once your physical assessment points toward failure or ischemia, you escalate to diagnostics. We have to confirm this distress at the cellular and electrical levels.
Which brings us to the biomarkers, primarily troponin and BNP. Let's start with troponin. The sources call cardiac-specific troponin T and I the absolute gold standard for acute coronary syndrome.
Because it is highly specific. When myocardial tissue becomes ischemic and the cells begin to necrose, the cell membranes rupture.
Right, they break open.
They dump their intracellular contents into the bloodstream. Troponin is a structural protein unique to cardiac muscle. If it is in the blood, cardiac cells have died.
But the danger here, the trap that intensivists and nurses have to avoid, is the timing, right?
Yes. The highest priority nursing action with troponin is correlating the timeline of the patient's chest pain to the lab draw. Even with high-sensitivity assays, it takes 1 to 3 hours after the onset of ischemia for enough cells to rupture and cross the detectable threshold in the blood.
So it's not instant.
No, if a patient experiences sudden, crushing chest pain and you draw on a troponin 20 minutes later, it will likely be negative.
And if you send them home based on that first negative draw, they could die of a massive infarction a few hours later.
Exactly. Serial draws are non-negotiable.
Right. Now let's contrast that with BNP, B-type natriuretic peptide. We talked about how an S3 indicates a volume overloaded, overstretched ventricle. BNP is the chemical signal of that exact same pathology.
Right. It's a hormone released by the heart itself.
Yeah.
When the ventricular walls are stretched to their mechanical limits by excess preload, the tissue synthesizes and secretes BNP. It travels to the kidneys and essentially forces them to dump sodium and water into the urine.
Natriuresis.
Exactly. It's the heart's desperate attempt to reduce its own preload.
Which makes it an incredible diagnostic tool in the ER or ICU. If a patient is severely dyspneic and you can't tell if it's a pulmonary exacerbation or heart failure, you look at the BNP. A massive elevation points directly to ventricular stretch and cardiac etiology.
Exactly. And finally, we look at the electrical tracing, the ECG. We understand the normal depolarization sequence, the atria, the AV node, the ventricles. But the sources highlight an abnormality that is incredibly easy to miss, the U wave.
Yeah, I really wanted to ask about this. The U wave is this tiny deflection that sometimes appears after the T wave. Why should an ICU clinician obsess over a wave that is so easily buried or just ignored?
Because a prominent U wave is a physiological siren for hypokalemia.
Low potassium.
Right. Potassium is the primary intracellular ion responsible for establishing the resting membrane potential of the heart muscle. When potassium levels drop in the blood, the cardiac resting potential becomes hyperpolarized.
Okay.
The electrical reset takes longer, which alters repolarization and creates that U wave.
And more importantly, it makes the myocardium dangerously irritable.
Exactly. Low potassium lowers the threshold for action potentials. The heart becomes electrically unstable. If you see a prominent U wave on the monitor, that patient is at immediate risk for lethal ventricular dysrhythmias, like torsades or VFib.
So the clinical picture is urgent. If you see a prominent U wave, your brain should immediately jump to hypokalemia, and your absolute priority action is to check those electrolyte levels and advocate for aggressive potassium repletion before the rhythm degrades into something fatal.
It perfectly encapsulates the intensivist mindset. You didn't just look at a squiggly line on a monitor, you recognized a cellular ion imbalance that was about to cause mechanical pump failure.
This has been an incredibly dense practical breakdown. We started with the mathematical engine of cardiac output and the Frank-Starling curve. We explored the hemodynamics of why tachycardia induces ischemia.
We covered a lot of ground.
Yeah, we moved to invasive pressure monitoring, analyzing the strict mechanical requirements of A-lines and PA catheters to avoid horrific complications like neurovascular occlusion. We translated failing pump mechanics into bedside assessment JVD, pulse deficits, the slosh of an S3 gallop. And we confirmed our clinical suspicions with troponin, BNP, and the elusive U wave.
It's really about seeing the entire physiological web at once. But Before we finish, I want to leave you with something to consider about where this field is heading.
Oh, let's hear it.
We spent significant time discussing the intricate setup, the risks, and the phlebostatic calibration of invasive PA catheters. But the sources note that non-invasive continuous cardiac output monitoring using technologies like bioreactance, bioimpedance, and advanced finger cuffs is advancing incredibly fast.
Getting the exact same continuous hemodynamic data without ever threading a catheter through a central vein and into the heart.
Exactly. As these non-invasive tools become just as reliable as the traditional Swan-Ganz, how does that alter the risk-benefit analysis in the ICU? If we can completely eliminate the risks of central line infections, arterial thrombosis, and catheter-induced dysrhythmias, will the invasive PA catheter become a relic of the past during your career?
It's a massive paradigm shift in how we monitor critical illness.
It fundamentally changes the equation of critical care.
It really does. Thank you for diving into this complex material with us. Keep anticipating the deterioration, keep connecting the cellular data to the physical assessment, and keep thinking like an intensivist at the bedside. We will catch you on the next deep dive.